Assalamualaikum warahmatullahi wabarakatuh. I'm Dr. Huda from Hospital Raja Maisuri Bandung, Ipoh. So I will proceed with my topic, thoracic trauma. Okay, so the objective first is to identify and treat life-threatening injuries encountered during primary survey. So we have the mnemonics, which is atom TC, A for airway obstruction, T for tension pneumothorax, O for open pneumothorax, M for massive pneumothorax, T for tracheobronchial injury, and C for cardiac tamponade. Second is to identify and treat potentially life-threatening injuries in secondary survey. And the third one is to identify and treat other significant thoracic injuries. So introduction, thoracic injuries are usually associated with high mortality and most die after reaching the hospitals. So most of the deaths are preventable and majority of them will not require any operative surgical intervention. The physiological consequences result from thoracic trauma is hypoxia, which is the most serious consequence, hypocarbia, and also acidosis. So we have to perform an initial assessment by doing primary survey with resuscitation of the vital functions, followed by detailed secondary survey and definitive care. So for the primary survey, we have to start with the airway. It is critical to recognize the thoracic injury that can cause airway obstruction. So for example, thoracic injury can be associated with a laryngeal injury, and patient can have a posterior dislocations of the clavicular head that can compress on the trachea and cause the airway obstruction. And any penetrating chest or neck injury, it can cause bleeding and the hematoma that can cause airway obstruction. So airway obstruction, first we have to assess by look, listen, and feel. We have to look for air hunger, any intercostal or supraclavicular retractions, and we have to look inside the mouth to look for any foreign body. Then we have to listen for the air movement at the mouth and nose, listen for any stridor, and also don't forget to listen to the voice quality. Sometimes patient can have a laryngeal or upper airway edema. They can have hoarseness of voice or muffled voice, okay? Then we auscultate the lung fields and feel for any crepitus at the anterior neck and palpate the region at the sternoclavicular joint to look for any dislocations of the clavicular head. Then if we found that there is a airway obstructions, we have to do an intervention, clear the airway by perform suction and placement of definitive airway when it is necessary. And when you notice that there is the posterior dislocations of the clavicle, then we have to perform a close reductions by doing abduction and extension of the shoulder. If we fail, then we have to grab the clavicle to alleviate the obstruction and keep in supine position. Usually post reductions, the dislocation will be stable. Okay, so this is the image of the top view of the rib cage. So this area, this part shows that there is a posterior dislocations of the right clavicular head. So it can compress to the structures here. It contains great vessels, trachea and esophagus. So if it compressed to the trachea, then it causes the airway obstruction. So this is the image of on how we perform close reductions of the posterior dislocations of the clavicle. We have to abduct and extend the shoulder, and we pull the clavicle up, okay, using fingers or using the bone forceps. If the close reduction is failed, then we have to perform the open reduction that usually can be done by the orthopedic. Okay, now we proceed with the tracheobronchial injury. It is an injury to the trachea and bronchus. It is unusual, but it is life-threatening. So majority of patients will die at scene. However, for those able to reach the hospital, we have to bear in mind that they will have a high rate of other associated injuries such as airway inadequacy, tension pneumothorax, and also tension pneumopericardium. The mechanism of injury that result in tracheobronchial injury usually will involve in high impact injury, and there will be a rapid decelerations that can occur during fall or even during motor vehicle accident. Okay, and the other mechanism of injury include blast trauma or penetrating injury to the tracheobronchial area. So this is the anatomy of the our airway, the trachea, okay, the main bronchi and the terminal bronchioles. So the 80% of the tracheobronchial injury occur at the distal part of the trachea up to the main bronchi, okay, about within 2 cm from the carina. And another 15% occur at the proximal part of the trachea, and the remaining 5% occur at the terminal bronchioles. Okay, this area is commonly occur because the distal part of the trachea is more mobile compared to the more fixed structures at the proximal region. So this is the bronchoscopy image of the patient, shows that there is a lacerations at the trachea. Okay, so patient with a tracheobronchial injury, they can present with hemoptysis, cyanosis, okay, they can have a tension pneumothorax, and they will have a subcutaneous emphysema at the cervical or at the upper thorax because of the air leak from the airway to the subcutaneous tissue. And when we insert the chest tube, there will be incomplete expansion of the pneumothorax, and you will see massive air leak or continuous air leak from the chest tube. So we have to suspect the tracheobronchial injury. Then the intervention, patient will need an intubation, and you have to bear in mind the intubation can be difficult because the anatomy are distorted from the injury, and they might have bleeding. So therefore, patient may require advanced airway skills. Then definitive care, the patient will need operative treatment. Okay, now we proceed with the breathing problems. To assess the breathing problems, we have to completely expose the patient chest and perform breathing assessment by doing inspection, palpation, percussion, and also auscultation. Okay, inspection, you have to inspect the respiratory rate, the depth of breathing, and also you have to inspect for any paradoxical movement of the chest, any wound over the chest, and also if there is any penetrating objects over the chest. Okay, then you have to palpate for the chest wall tenderness, palpate for subcutaneous emphysema, and percuss to look for any dullness that might indicate hemothorax or hyperresonance in pneumothorax, and auscultate, listen to the equality of the breath sounds, auscultate for any presence of a muffled heart sounds. Okay, if there is a reduced breath sound, it can tell you that this patient might have a hemothorax or pneumothorax. Okay, so tension pneumothorax, the pathophysiology. So tension pneumothorax is one of the life-threatening injuries that you have to identify during the primary survey. So the pathophysiology is when there is injury to the lung parenchyma, then the air can goes into the escape from the lungs and goes into the pleura, and the pressure will develop in the pleura, and it will cause the affected lung to be collapsed. And when the pressure is high enough, it can cause a middle sinus shift, and subsequently will decrease the venous return, and subsequently will compress the opposite lung and reduce the cardiac output. So patients can have an obstructive shock, and tension pneumothorax is basically it is a clinical diagnosis. Okay, so you don't need an imaging to diagnose the tension pneumothorax. So this is the symptoms and signs when the lungs is collapsed. Patient cannot properly ventilate. Okay, so patient can present with respiratory distress. Okay, and patient can complain of chest pain, air hunger, cyanosis, tachycardia, tachypneic, and on physical examination, you will see that there is a tracheal deviation and unilateral absence of the breath sounds. You can perform EFAS at the bedside as well to look for signs of a pneumothorax. And the intervention, you need to perform a needle decompression followed by chest tube incision. Alternatively, you can perform finger thoracostomy. So this picture shows that he was performing needle decompression on a patient at the second intercostal space. But now you can perform needle decompression at the safety triangle for intercostal space at the anterior axillary line. Okay, now we proceed with the next diagnosis, which is open pneumothorax, or it oftenly referred to as a sucking chest wound. Okay, open pneumothorax, of course, there will be a visible open chest wound. And so the air from the atmosphere can enter into the pleura. Okay, and usually the wounds will have a large enough defects. More than the diameter would be more than 2/3 of the tracheal diameter. So patient can develop similar symptoms with the pneumothorax. Okay, patient can have respiratory distress that will lead to hypoxia and hypercarbia. Symptoms and signs will be similar with the pneumothorax. With an addition, there will be visible open chest wound. Okay, so this is the image of the air from the atmosphere that can enter into the pleura, and then when the air is large enough, then they will create a pressure because they can go in, but they cannot exit from the pleura. Then it will cause a collapse of the affected lungs. Patient will have a respiratory distress, and patient subsequently can have a hypoxia and hypercarbia. So the intervention, you need to perform a sterile occlusive dressing on 3 sides. Okay, leave it open on the dependent side or on the gravity side. So it will act as a flutter valve effect. Okay, so the air can exit the wound, but they cannot enter the wound. And please avoid tapping all 4 edges because you can convert it into tension pneumothorax. And it must be followed by the chest tube incision. But the chest tube incision must be removed from the wound, and don't follow the wound track because it might guide you to wrong path, and it can guide you to injure the lungs or even diaphragm. Next is massive pneumothorax. It occurs when there is a destruction of a systemic or hilar vessels, when there is an aortic rupture or myocardial rupture. So the massive pneumothorax is defined by the accumulation of blood inside the thoracic cavity, at least 1,500 mils. Okay, it can compress the lung and subsequently will cause a hypoxia and hypercarbia. Patient can present similar with the tension pneumothorax. They can have a respiratory distress. They can have a compensatory mechanism by having a tachycardia and tachypneic. And on auscultation, there will be decreased breath sounds. And when you perform percussion, it will be dullness. Okay, massive pneumothorax also can pose a circulatory problem because patient lose a lot of blood in the thoracic cavity, so they can have a hypovolemic shock. Okay, so this is the image of the chest X-ray, shows that homogeneous opacity on this side, and then the trachea has been shifted to the normal side because of the pressure. Okay, so the intervention is by perform the chest tube or tube thoracostomy, and you have to insert large IV cannulas and give crystalloids to patients and early blood transfusion. Then the patient will need urgent thoracotomy. Next is cardiac tamponade. it will cause a circulation problem. Okay, when there is the accumulation of fluid in the pericardial sac, they will create the pressure, and then they will decrease the venous return, and subsequently patient will have a decreased cardiac output. Okay, the classical signs that we call as the Beck's triad. Patient can have a distended neck vein, muffled heart sound, and hypotension. But you have to bear in mind that these signs is basically very not sensitive. It only present in about 10% of patients with cardiac tamponade. Therefore, it is important for you to perform EFAS that can effectively diagnose cardiac tamponade. Okay, so this is the ultrasound image of the heart. It shows that there is a pericardial effusion. That is the volume is large enough, and it compressed on the right ventricle. So this is the left ventricle. So patient can have a decreased cardiac output, and patient can have a shock. Okay, so intervention, patient basically will need an emergency thoracotomy or sternotomy. That will be the definitive treatment. However, in emergency department, we can perform pericardial synthesis that will act as a temporary measure. But since we have an ultrasound, so don't do it blindly. Please use ultrasound guidance when you perform the pericardial synthesis. Okay, now we proceed with the secondary survey. So the objective just now is to identify any potentially life-threatening injuries. Okay, it might not be obvious on initial physical examinations. Therefore, you will need an adjunctive studies such as X-ray. You might need even a CT scan or other studies to help you to diagnose the injury, because it is easy to overlook. So it requires high index of suspicion based on the mechanism of injury, and also the clinical signs that is based on the thorough physical examination as well, that can guide you to find the other injuries. Okay, so one of it is a simple pneumothorax. Okay, when the air enter into the interpleural space, and then the lung will collapse and causing ventilation perfusion mismatch. Therefore, patient will have a respiratory distress. It will need a comprehensive physical examination to diagnose it, and then the agent study, you can perform a chest X-ray and EFAS to look for signs of a pneumothorax. The intervention, patient will need a chest tube. Okay, so this is the chest X-ray of the patient with a right pneumothorax. Okay, so see from here, there is the trachea still remain in the center, and this is the pneumothorax, and the lung is being collapsed because of the pressure developed in the pleura and causing the lung collapse. Okay, so this is the ultrasounds findings to show you how to differentiate between normal lung and also pneumothorax. Okay. For the normal lung, the sliding sign will be present, while in pneumothorax, there is no sliding sign. And when you put at the M1 marker at the region where there is no sliding sign, you will see for pneumothorax, you will see the barcode or stratosphere sign. Okay. However, in normal lung, you will see that there is a seashore sign. This is a sea and shore signs. Other signs that you have to look for in the M mode, you can look for lung point and also lung pulse. That can help you to diagnose the pneumothorax as well. So this is the how to put the chest tube. Okay, to create the track, you must make a vertical incision over the chest at the safety triangle. Okay, when you insert the chest tube, use your finger as a guide, and please do not use trocar to make a track to insert the chest tube. It's very dangerous. It can penetrate into your lungs parenchyma. It can injure your diaphragm, or it can injure even your heart. So this is the image that shows how to perform the chest tube. First, you have to identify the safety triangle and give a local anesthesia, and use your finger to guide you to the space, and you put your finger above the ribs because you want to avoid the neurovascular bundle at the below of the rib. Okay, then you insert the chest tube, use your finger as a guide. Okay, and then you connect to underwater seal. Okay, next is hemothorax. It can occur when there is a laceration of lung, great vessels, intercostal vessels, internal mammary artery, or thoracic spine fractures. Okay, usually the blood accumulation will be less than 1,500 mils, and the bleeding usually self-limited, and patient most of the time will not require any operative intervention. So to diagnose, you might need an adjunct studies such as chest X-ray and also EFAS. Okay, so this is the X-ray that shows the left hemothorax. There is a meniscus signs with homogeneous opacity on the left. However, when the patient is supine, you will just see there's a haziness all over the lungs. Okay, because the blood accumulates in the dependent part of the thorax. And from the ultrasound, you will see the pleural effusion above the diaphragm, and you will not see the curtain sign, and there will be a rib sign. Okay, so next diagnosis is the flail chest. It occurs when there are two or more adjacent rib fractures in two or more places. So at least two or more adjacent rib fractures at the two different parts. So usually it can be recognized by the presence of a paradoxical movement of the chest wall that is better appreciated when you perform a palpation rather than inspection. Okay, next is so the principal management for the flail chest is basically you have to prevent hypoxia by giving supplemental oxygen, judicious fluid administration, and also good analgesia. So next is the pulmonary contusion or bruised lung. It can happen even though there is no rib fractures or flail chest, especially in children. Okay, there is a blood and fluid accumulation that result in ventilation problem and causing hypoxia. Pulmonary contusion can be subtle. Okay, the ventilatory failure can be subtle and it can progressively worse over time. So you have to closely monitor the patient. And it can be underestimated in the elderly because of the limited ventilatory reserve. So the intervention, patient will need a supplemental oxygen, adequate ventilation. Even some of the patient in severe cases, they will need intubation and ventilation to prevent from the hypoxia. And they will need adequate analgesia and judicious fluid administration. Okay, and you need to monitor carefully this patient as it can worse over time. Next is a blunt cardiac injury. It results from the myocardial contusion. The blunt cardiac injury can result in myocardial contusion, cardiac chamber rupture, coronary artery dissection, thrombosis, and valvular disruption. So patient can present with hypotension, arrhythmia, and wall motion abnormality that you can look at the echo. When you perform an ECG, patient will have a variable ECG changes from the sinus tachy to frequent premature ventricular contractions, AF, bundle branch block, okay, and ST segment changes. So the intervention is basically patient will need adequate analgesia, and patient will need a cardiac monitoring. If Any presence of arrhythmias, you have to treat as per SLS protocol. Okay, so next injuries that you have to look for during the secondary survey is a traumatic aortic destruction. The common cause of sudden death post-injury due to free rupture. So there will be exsanguinating bleed. The mechanism of injury, usually it involves decelerations, for example, during fall from height or even during a motor vehicle accident. And the chest X-ray findings, there will be a lot of false positive and false negative. Therefore, we will need to monitor and re-evaluate the patient. Okay, traumatic aortic destruction, patient sometimes may not have any specific signs and symptoms because they will sometimes some of them will only have an incomplete laceration near the ligamentum atherosus of the aorta with intact mediastinal hematoma or intact adventitial layer. Okay, sometimes so it is quite difficult to diagnose. You must have a high index of suspicions to detect it. Okay, so this is the chest X-ray findings. A lot of characteristic finding in the chest X-ray include widened mediastinum, okay, obliteration of the aortic knob, deviation of the tracheal to the right, okay, the presence of pleural or apical cap, okay, and a lot more that you can see from the chest X-ray. However, don't forget that patient can still present with the normal chest X-ray. Therefore, you might need further imaging, for example, CT chest. Okay, you might need to perform transesophageal echo to look for the intimal flap. So the intervention, if you identify there is a traumatic aortic disruption, you have to give a good analgesia to the patients, and you have to keep a heart rate less than 80 and the blood pressure, the MAP at least 60 to 70 because we want to avoid further shear force to the injury area. Okay, and then of course, patient will need urgent refer to cardiothoracic team for repair. Okay, next is a traumatic diaphragmatic injury. It is more common to occur on the left side or left diaphragm because on the right side, there's a lever that can protect the right diaphragm. Okay, usually it can result from the blunt trauma to the chest that will cause a large radial tear of the diaphragm and causing a herniation. It frequently means initially, okay, so the definitive treatment, patient will need operative intervention. Okay, so this is the chest X-ray showing the elevated hemidiaphragm. And you can see there is a gastric tube in the thoracic cavity. So you have to be careful when you insert the chest tube. You might be put in the intra-abdomen. So blunt esophageal, next is a blunt esophageal rupture. It is a forceful expulsion of the gastric content into esophagus from the severe blow to upper abdomen. So it causes a linear tear in lower esophagus. Then the content in the esophagus can leak into the mediastinum. Therefore, it will lead to mediastinitis and empyema. Patient can complain of severe chest pain out of proportion to the injury. And it is basically can be life-threatening as well. On the chest X-ray, you can see the presence of the particulate matter in the chest tube. When you insert the chest tube, you can see the presence of a particulate matter. Or when you perform an chest X-ray, you can see the mediastinal air. So the treatment, patient will need repair, surgical repair, and drain the drainage of the pleura and mediastinum, because you have to clear out your to clear out the contents of the esophagus from your pleura and also mediastinum to avoid mediastinitis and empyema later. So this is the chest X-ray that shows the subcutaneous emphysema and then also the pneumomediastinum. Okay. Other manifestation of chest injuries, it might not be life-threatening but can cause significant morbidity, such as subcutaneous emphysema, crush injury to the chest, fractures of the ribs, sternum, and also the scapula. So subcutaneous emphysema, it is basically gases in the subcutaneous tissue that can result from various injuries. It can result from the airway injury like tracheobronchial injury, lung injury, and also blast injury. It is basically does not require any immediate treatment. However, it is very important for you to find the cause and treat the cause. Okay. Chest tube might be indicated if patient is on mechanical ventilator. And then patient might need a drainage of the subcutaneous emphysema when it caused the problem to the soft tissue, such as a compartment syndrome. Okay, so this is the chest X-ray of the patient with a subcutaneous emphysema. So you will see there's a lot of hair inside the subcutaneous tissue, okay, up to the neck. And then this is the chest tube that has been inserted for the ventilated patients. Okay, next is the crush injury to the chest or traumatic asphyxia. So traumatic asphyxia is basically caused by intense compression of the thoracic cavity, thus causing venous backflow from the right side of the heart into the veins of the neck and brain. So patients can present with cyanosis, swelling over the face, and petechiae over the upper part of the chest, arm, and also the conjunctiva. Okay, because of the superior vena cava compression. And patient can also have a cerebral edema. So it happened with the high impact injury, so you have to look for other associated injuries, okay, and treat the associated injuries. So this is the image of the patient that presented with a petechiae at the upper torso and swollen or hyperemic face. Okay, other than that, the other things that we have to look for in patients, it is rib fractures, sternal fracture, and also the scapular fractures. So this is the X-ray of the sternal fracture, and this is the X-ray of the scapular fracture, and multiple rib fractures on this X-ray. So for the rib fractures, for example, when there is first or rib fractures, you have to, it suggests that the patient have a high impact injury. Therefore, patient will have a higher risk of internal injuries that you have to look for. Okay. The most common area that the patient will have a rib fracture is around 4 to 9 ribs, because they are less mobile as they are attached to the sternum. And so they are most commonly injured. And if patient have a lower rib injury, for example, 9 to 11 rib injury, they are associated or increased risk with abdominal injury. So you have to look for the intra-abdominal injury as well. So for the rib fractures, sternal fracture, the adequate analgesia is the key to reduce the incidence of atelectasis, pneumonia, and respiratory failure. So in summary, thoracic injury will have a high mortality, but majority of deaths are preventable. And majority of the life-threatening injuries that we have discussed are due to thoracic injury, which is our pneumonic atom TC. And majority of these injuries can be treated by simple interventions. Most of them will not go for operative intervention. And bear in mind and always remember that most of the potentially life-threatening injuries are not apparent on clinical initial examination. So high index of suspicion is very necessary. Therefore, I end my presentation. Thank you very much on your attention. Thank you.